Hey, everybody. I apologize for being a few minutes late. As a long time no see, no long time. We had a little technical difficulty. I think we tried some new settings, and what's old is new, and what's new is old. I think you're supposed to keep doing dance with the one that brung you, they say. But this is our first meeting of the year. I'm very, very excited. I'm sorry I'm eating apple, but they kept me on the phone all morning long. So I'm just trying to get a little nourishment to keep me going because I know this is going to be a robust discussion. Because who do I see? I see some in the city we call them old heads, and so we got some old heads. We got like Angie Gray, old head. We got Ariel. We got Jill, old heads that are in the game in Appalachia. And so I wanted to really kind of start off the year really talking about, I think, honestly, some of the super successes that we've had in 2023. Because, I think we always start out talking about stuff that is bad, like it's all horrible. And there are horrible things that are happening in the Appalachia region, but there are also things that are going on that are good, that are happening. And I want to talk about those too. I know CEG's had some great successes in 2023, and I keep telling people we're getting ready to bust 2024 in the mouth. So I want to start out, Angie, with you, probably because I've known you longer. So that's just me taking a license with how long we've known each other. So, Angie, tell the people what you're doing these days. Tell the people what you're working on. Because I met Angie working on our first project over in Morgan, not Morgan town, but in Morgan County, right? Isn't that right? Okay.
Yeah, well, I think we go back even before that one. Yeah, on
All
early
right.
days of harm reduction and syringe exchange. Yeah,
Yep.
access. Yeah. So I'm Angie Gray. I was looking at the uh, background for community education, 30 years. I'll be a nurse for 30 years this June. Hard
Right.
to believe. So yes, I'm an old head. Tony. Have a pleasure to work with Tony and meet her years ago. We think a lot alike, and can see the positive change that needs to happen to benefit our Appalachian folks. I mean, I was born and raised in West Virginia on the Eastern Panhandle. I'm currently working for WVU Medicine at Berkeley Medical Center and do some work at Jefferson as well. Today, I'm representing the West Virginia Hope and Action Alliance as their chair for 2024. And I love, Tony, that yes, there is bad things. There is a lot of work to be done, but focusing on some of that positive and along with what your topics are today, I have some very positive things in acute care, that being able to integrate harm reduction into acute care. And it's just a beautiful thing. And I would love to see other hospitals, replicate this across our state and Appalachia, because pretty powerful, especially dealing with prevention of overdose.
Right. For those of you who might be new to this and not true to this, I interrupt all the time, and so or I change the whole idea of what we're going to talk about in the middle of it because I see these calls as like we're having a cup of coffee together, and we can talk about stuff. And you know how you go, you meet your friend for coffee, and you say, girl, I'm just coming here to chit chat. And then all of a sudden you're there and you're talking to them and you're like, you got to talk about the kids. And then you talk about this and you talk about that. And you're like, oh, what about? That's what this space is really designed to be for. So, for example, Lee and I had a call with HRSA this morning. And what we invited HRSA to do is to come on and talk about the breadth of what the services and tools are that HRSA can offer and how we can make them a utility and make them useful in this part of the country because many of the organizations and institutions don't have the organizational capacity to maybe apply for Ryan White or what are the other things that they can do to get those resources to the people in this region that need them so desperately? So I want to make sure that we know and that you know this isn't that kind of party where you just like, oh, you just got to sit here and listen. You might get called on and you don't know why you got called on, and you'll be like, wait a minute, I'm not a part of the presentation panel. Everybody who's on this call has the potential to be a presentation partner, in part because you got a piece of information somebody else don't have. I know a lot, Angie know a lot, Jill know a lot, but y'all know a lot more because you're in whatever county or in whatever state. And you might need help, or you might need to share something with us that we don't know. So, Jill, I'm coming to you. And a part of the reason we wanted to talk to folks is that I believe a couple of things. One is that what we've got to do is get our primary care partners, our MAP partners, and others to help us create a continuum of care. I think particularly our MAP partners, we look around, we say, in this part of the country, so for those of you who are new, I have a philosophy that there's a train roaring through the Appalachia region, and that the engine of that train used to be the opioid crisis, and now it is a poly-use crisis that's the engine. The next car of that train is hepatitis C, next car of that train, hepatitis B, hepatitis A, economic development, workforce development, educational attainment challenges, with the caboose of that train being the HIV outbreaks that we see in West Virginia and across the other parts of the 13 states. But I also think it's critically important that we think about coal as the environmental impact, the economic impact, and the psychological impact that coal has had on the Appalachia region for decades. And that our job collectively and our job organizationally is to stop that train in its tracks with everything that we have, with every tool that we have, with every fiber of our being. But most importantly, that none of us can do that alone. So we want to bring in our healthcare partners, our economic development partners, our workforce development partners. That's why we're doing the Appalachia Summit that we're doing in May. And that's why we need all of you to be a part of that as well. Jill, can you tell the people who you are and what you do and why y'all do what you do and where you do what you do?
Sure. So I'm Jill Martin. I'm the Clinical Director of Behavioral Health at the Kentucky Primary Care Association. So we serve the entire state of Kentucky. We have about 100 member clinics that are federally qualified health centers or rural health clinics. And we work for them. So we help them help patients, is what I like to say. So in my role as the Behavioral Health Director, I oversee our Kentucky Opioid Response Effort Grant, which put peer support specialists in primary care clinics in the state of Kentucky. To my knowledge, for the first time, I haven't seen peer supports prior to that grant 4 or 5 years ago. And then it was also to expand access to MOUD, medications for opioid use disorder. So we had a lot of barriers, some legislative barriers, some barriers when it came to just stigma, workforce barriers. So we've learned a whole lot over the last 4 years with that grant, and we've accomplished a whole lot. It's something that I'm really proud of. We are applying for a grant right now to focus on adverse childhood experiences and how to strengthen families and build resiliency. We have a lot of different folks at KPCA. So we have folks that specialize in workforce, folks that specialize in credentialing, billing, coding, behavioral health, social determinants of health, enrollment, getting people signed up for insurance so that they can receive good quality care, So that's what we do at KPCA. We try to help clinics help patients.
All right, so thanks. So again, I always have a big idea and they always tell me to stop. So, but one of my big ideas is MAP providers. So one of the changes or several changes occurred in January around what can be billed for using community health workers, the linkages to care and that sort of thing. And that's a bit of what I know you're like, is that what she said in the memo? I don't think somebody told me that in the email that that's what we talk about. But now that's where I'm at today. Jill, you'll get used to it. It's just how my brain works. So one of the grants, honestly, that in all transparency, we've applied for is that we just applied for a big grant with the Appalachia Regional Commission. And one of the things I want to do with this is be able to train MAP providers, particularly on what they're leaving on the table. With whether that's 340B or whether that's linkage to care or whether that is re-engagement or screening for HIV or hepatitis C or the cure rate that a community health worker can really show how you can bring patients back into care and relieve patients to care. Can you both talk to me about kind of how you see community health workers working in that kind of framework? Is it a value? Because I know we call peer recovery coaches, and I think those have a different role. Community health workers, I think that I don't know, there's like 15 million names from them. And I know we're in West Virginia, we're actually even trying to get a certification process through. Can you talk a bit about kind of the value, or if you see a value of community health workers, and what we can do with MAT and other, I think particularly behavioral health providers, of how to use community health workers?
Jill, I don't know if you want to go first or if you want me to, but okay. That's part of the program here that I clinically supervise. We have three peer recovery support specialists, and it just changes everything. It really does. So we came in October a year ago, and I came a little bit before then, trying to lay down, the I'd say the plan, and it's really infiltrating culture and changing the culture. So we started in the emergency department, where we all know our people who use drugs are not treated well. Typically, we as healthcare workers have actually, the way we treat people sends them back out our door without help. I'm a harm reductionist. So, in my days of working harm reduction clinics, people would have huge, huge abscesses, and they'll be draining them over their kitchen sink before they will ever try to access healthcare, because of the stigma and the way they've been treated. And bringing in peers alongside, with the harm reductionists, was a beautiful thing. It took a while. I had to bite my tongue for a while. It might not have been the right moment in time, right, to do that education, but then come back 2 days later or something with that nurse or that doctor. And what I was able to do was, every time they thought the person using drugs was lying, I was able to track it down and prove that they were actually telling the truth. Because I think we have this mindset that they always manipulate, they always lie, so they don't become part of that care and their care plan. And that changed this culture. And then when they started treating people who use drugs differently, as humans, as we should everyone, then they saw the behaviors change of the people who use drugs. Grateful, thankful, apologize for the way they had acted prior visits. And now all of our providers in the ED will tell you they are the easiest, most pleasurable patients that they see and take care of. And we have several programs here. One is a bridge to recovery, where if somebody is, or we'll get them appointment if they don't already have one, to an outpatient MOUD provider. And we know that could be 2 weeks, 3 weeks, 4 weeks out, and you might lose somebody in that time. And, preventing them from getting on life-saving medications, we'll bring them through the emergency department and go ahead and get them initiated on buprenorphine. That way, they're more likely to make that appointment in 4 weeks, and they're going to be alive to make that appointment in 4 weeks. We also, sorry.
Yeah, Angie, no, I want to jump in here. And so when you do this, are these folks billed as a community health worker contact, or a peer recovery contact, or a community engagement or a linkage to care contact?
So not yet, because the state of federally, we had to wait for things to happen, and that's happened. We're hoping that in the state of West Virginia by spring, which we all know how things get delayed, we'll be able to bill for services. So they have an IPN number, just like doctors do, so that they can bill. Right now, we're running purely off grants. All of our positions are grant funded. So we don't want to go backwards, because every provider in that ED will tell you how valuable this is, and this is a program that cannot go away. So we really need to get that billing and sustainability in this state up and running, because it changes everything with the interaction with the patient and with the staff, and you see better outcomes. You really do. And then to take that another step, because I do think in community and population, we need them out in the community, meeting people where they are, letting them know about the services, and offering testing and all those kind of things right in their own community. And I think that is a piece that's lacking, especially for hepatitis and HIV testing, is really getting to where the people are and meeting them there and doing that rapid testing. We do test everyone. You'll love this. I don't know if we're the only emergency department in the state of West Virginia, but everyone who has a diagnosis of substance use disorder gets tested for HIV and hepatitis A, B, and C.
Very good. And Jill, I know that Kentucky actually does have a certification program for its community health workers. Can you tell us a bit about, are providers using that as a billable on an IC? And I would imagine ICD-10 codes exist. For those that don't, that's the billable code that you bill back to Medicaid, because we want to have a conversation with CMS, I think, about this as well. But go ahead, you can.
Yeah, so to my knowledge, our clinics are billing for CHW's fee for service. So even though we function under that PPS rate model, they're billing those separately fee for service, is my understanding of it. And our clinics are utilizing CHWs. A lot of them have been for years, and just they're either paid for through grants or the clinics pay for them. A lot of times they've been called something else, but essentially, when I think of the role of CHWs and the way that I think most of our clinics are using them is really to address those social determinants of health. So when you think about like Maslow's hierarchy of needs, the providers may want to help patients reduce their A1C or help them manage their diabetes or their high blood pressure. But really, if you have a patient coming in and they're just worried about where they're going to sleep at night and they're hungry, they don't really care about those other things. Like we know just from studying human behavior, like you have to address those basic needs before you can build on those and think about other things. So the CHWs really come in and help with that stuff. They do the prepare tool. A lot of clinics, they do that every single time they see a patient and they come into the clinic, and then they help address those social determinants of health so that they're able to focus on their health when they come in. Now, we have peer support specialists or recovery coaches, which is a separate position. They are only able to bill right now through rural health clinics, and that was because they were not recognized as approved providers in our legislation. So we had to do a lot of advocacy on behalf of our clinics to be able to get that changed. We're still waiting for the FQHC reg to be in place, but right now we have through our grant 25 peers in clinics that are paid for through grants, and some clinics have added the additional peers themselves that they just pour out of their own pocket, because what we have found is that you put a peer support specialist in an exam room with a provider and you explain to them what the role is and how to utilize the position, and all of a sudden providers refuse to work without peers. So they will see an extra patient a day to be able to pay for their peer salary. Because they don't want to do it without it. The peer is the bridge between the patient and the provider. So we would have clinics that were doing discharge letters, like 3 strikes, you're out. You have 3 drug screens where something's in it that's not supposed to be, or something that's supposed to be is not, and we're just going to dismiss you from our clinic. You have to find another primary care provider. All of a sudden, you put a peer support specialist in there with them. The provider's still under the same stresses, the same time crunch. They don't really have any more capacity. You've got 7 to 15 minutes to see a patient, to address all of their issues, and then to make sure that they're safe and that you're prescribing responsibly when they leave there. You put a peer support specialist on that treatment team that can follow the patient, literally take them home, connect them to a recovery community, an NA meeting, help them find a food box, go pick them up. A week later, bring them back in to see the provider. All of a sudden, we have providers that are willing to write medications for opioid use disorder. They're willing to treat people. Having the peer introduce the provider to a patient and say, listen, I want you to meet this provider. Here's what you can expect, but then can also communicate to the patient, like they've got enough professional training and knowledge that they can communicate what the provider wants to say in a way that the patient can hear it and understand it, but then they can communicate on behalf of the patient to the provider, like this is what they're trying to tell you. And it's just the bridge. So providers are refusing to work without peers. So I think we're going to see that grow tremendously, I hope, in the next few years.
Do you guys track like increase in revenue of clinics that use peer support, whether it's community health worker, peer recovery coach, etc.? Do you track any sort of metrics like, okay, this is how much their clinic increased in revenue, or this is how many patients were retained in care, or anything like that?
So some clinics, each clinic tracks, they do their own data tracking. Some clinics track a little bit better than others. That is one thing that we said if we could do it over, that we would do a little bit differently. We would collect a little bit more data on the front end. We are better positioned to be able to do that. We have, some of you all may be familiar, we have just started using Azara. So we will be able to do a lot of data collection across the entire state, across all 100 clinics that are our members. So we will have better data collection in the future.
All right. Hey, I know we have a person on the. Hey, Karen. Yeah, I'm talking to you. You're like, why am I calling your name out? Because you guys do some community health work stuff too. Do I remember this correctly, or good as Good Samaritan? Is that right? Yeah, I'm talking to you.
Yep, I'm muted. We do outreach. We don't have a community health worker, but we work with the patient. We work with the patients, and we are the bridge to whatever services are needed, whether it be those things, social determinants of health, or if they need Narcan, if they need whatever it is that they need. I mean, we're a safety net. Mm-hmm. That's what we are. We're a safety net.
And so here's my question actually for the three of you. I mean, Angie, you're in West Virginia where there isn't a certification program. So I think that impacts the way that providers either use the service or don't. I think, Karen's in a position where this is what the organization does. And then what I'm looking at with Jill is like, we're looking at Kentucky that actually has a certification and has state reimbursement and federal reimbursement. Tell me what you think we have to do with providers to get them ready and to get them to understand the value of this.
I think you said it earlier, data. Now, quantitative and qualitative data, right? We're always hidden. You have to have them both. Stories are powerful. The real of what people go through is powerful, right? Proving to our providers the barriers that they've had to even get here and beyond, right? And then when they see that, but then also that economics, because like you said, economics is a big part of it. So I think if we could start tracking somehow the reduction of emergency room visits and ICU visits, right there is going to be the return on the investment for those who need this, to see that economic power of that. I know it's happening. Getting a good data collection system that really shows that, I just don't think it's there or friendly. I can pull out some stuff, but not in a way that is as useful as and as impactful as it could be.
I agree, Angela. And I will also say that we started with early adopters. So those folks that already have the capacity and the infrastructure to be able to take something else on. And then we funded the position with grant funding. So they were willing to take it on because they didn't have to pay for it and they were willing to try it out. And then you educate them and you let them have a really great experience and talk about how it's changed their work culture or their workflow or their finances. When you have a clinic that can hop on a call and tell other clinics about their experience, and their experience is our PPS rate was increased by $50 because we now offer medications for opioid use disorder and we didn't before. A CEO wants to hear that. They want to figure out, how do we do that? And when you then have providers say you can't do it without the treatment team, you've got to have your CHW, you have to have your recovery coach, you got to have support for your providers. I think that is really a testimony.
Right. And Jill, sorry, Tony, Jill just said something very powerful because we've also embedded them into all the inpatient floors and they get consulted, right? So we've taken it beyond the emergency room in the hospital, and now it is on every inpatient floor, including mom and baby. What I see peer recovery support specialists or community health workers doing is they're bridging that care team. They are bringing that care team together and actively making the patient part of that care team and have input, as well as, and they are educating the doctors a lot of times, right? So I think that is the beautiful thing, is that they're bringing everyone together into that plan of care.
Yeah. And so I'm going to come back to you in a second there, Karen, because I know you're chomping at the bit. I know you're like, I didn't sign up for none of this. But I wanted to hang on, because we got hang on, where did she go? West Virginia Primary Care Association is on here. And it's, if I had my reading glasses on, that would have helped us all. It looks like Miss Smith. Where are you?
Yeah.
There you go. There you go. I see you now. And so what I want to do is that I want to make the distinction. I understand that we don't have a certification in West Virginia, and we were looking a lot at the difference between recovery coaches, community health workers, lay health workers. They all kind of get these different classifications. But in your email, you said something, or not your email, but that tells you how old I am. In your message, in the chat, you said, I can let you say what you said about the system that you use, but this was my next question, actually, which is, how do we get providers to change their ICD-10 codes or their intake systems? Because I think that if we can do that, that's the first step in this. But you go ahead and tell me about what you put in the chat.
Sure. Yeah. Just hearing what Jill's talking about in Kentucky. I would say we might be flip-flopped a little. We are working really hard to build up the data to get our federally qualified health centers on board. Each state's primary care association / HCCN works a little bit differently. All of our 34 member community health centers are autonomous, so we sort of act on their behest. So as we're trying to get them to sign up to work with individuals like this, to get them into their centers, which some of them do already, we're finding it's a little bit easier to have the data to bring in the folks rather than bring in the folks and gain the data, which sounds a little backwards. I know you need to do the work to find the data, but we are utilizing Azara, which, like Jill mentioned, really helps to track all the EHR data coming in and use it in more powerful ways. We're also just before this call got off the phone with a project planner for Find Help, which is a specific platform meant to connect all of the local resources for SDOHs into a platform that everyone can access. So your doctor could access Find Help via their EHR and Azara to find that housing. The software helps to get that loop closure, connect them to that housing organization in whichever county you are in, and then really have that data. So the technology is being built. It sounds a little quicker here in West Virginia, but the embedding sounds like it's working a little bit quicker there in Kentucky. So anyway, I just wanted to say this stuff is happening at the broader level, but I'm here to hear these things and to hear what's needed. So
Carol, I'm glad you're here, Ms. Smith, because what I want to ask you then is a very kind of specific and personal and nuanced question, but what do we have to do to get providers ready to change their internal technology to do this, right? Because we got to get the provider on board to say, yeah, hey, you know what? I want to put in a new system that's going to let me track these intakes or let me build this back, because it's not like it's not like the olden times when I started and you had a pen and a paper and you filled out a form and you sent in a bubble form or you sent in that form. All this stuff's electronic now. It's blippity bloppity bloop.
Yeah, I mean, it's a little bit different between a federally qualified health center and say a private primary care system. For HRSA, our federal folks who fund us kind of force some of this stuff. So that's a piece of it, right? The other is that the role of a primary of a community health center at FQHC is to support the community as it's needed. So that is the mission. Equity is in the foundation of it. And it's a requirement of our funding. So while many of our providers can be hesitant to utilize it, if this is the way the population need goes, they come to us and say, how do we make this work? So the Primary Care Association is doing that. Now that's at, a little bit higher, and we do lots of implementation, lots of training. That's another part of what we do. But yeah, that doesn't really answer your question, but that is how we approach it.
It kind of does, but then, I mean, like I told you, we're having a cup of coffee. It's just you and me. All these people aren't here, and Hersa never here. What I'm getting ready to ask you. So we just had a call with Hersa this morning, and they basically said, we don't know. You got to tell us what you need. If I was gonna get on the phone and say, I'm not naming no names, but I heard from a regional primary care association that this is really how they need HRSA to change. What would y'all all tell me HRSA needs to change to make it more effective and more efficient for rural? Here are the people we're talking about. Rural health clinics. I'm talking about the community health centers that are there. I'm talking about the FQHCs that are there. And I'm talking about those behavioral health practices that might be providing MAT to under 15 patients, right? Because that's a lot of who we have. Folks that started off as a therapy practice and are now like, okay, I can be 15 with this license, 20 with this license. Tell me what to tell her. Because I mean, Lee's on here somewhere, but that's what they told us today. Tell us what the people need. How do we get to everybody we need to get to? I told them first, eliminate the rural health calculator, because the reality is that it doesn't work for a lot of our small providers in the Appalachia region, because once they put in their zip code and they're across the street, they're out of it. We also need more infrastructure for them to be able to respond to HRSA large opportunities, because a lot of these organizations don't have the infrastructure to respond to those large RFPs. Now I'm going to let you answer the question, because I talk a lot. You might not have known that until you got here, but now you know. Go. Ms. Smith, that's to you.
I mean, yeah, we had HRSA at our leadership forum back in September, right? And we asked we ask, how do we make these things happen? And HRSA standing there in front of us says, well, what do you want us to do? And we say, well, how do we get this to do? It's kind of this cyclical thing. I don't know. It's a good question, but I don't know the answer. And, I don't know, other folks here who might have better support from HRSA. Also, we don't work, well, we do, but our community health centers have their HRSA folks. So there's this kind of disconnect between what we're able to say and what they're able to say. But it's a good point.
I mean, I'm telling you, I'm going to say it. I don't have to say who said it to me. I mean, and I say, you know me.
We need money. We need money. That's the thing. HRSA, well, Congress needs to stop acting a fool and just get themselves put together. But HRSA needs to give us more money. If we're going to support more things and more people in more rural areas, we need more resources.
So do the clinics need more money? Do the rural health clinics need more money? Do the FQHCs need more money? Do the behavioral health practices need more money? Who needs more money? Let's drill it all the way. Who needs more resources to come out of? What is that? That's a big dog you got there. Came over like a wolf.
My coworker. Everybody, all of the. I mean, and it's not necessarily just funding, right? Like the National Health Corps that helps get folks hired into these spaces, right? Like that program needs to keep being funded. There needs to be more money to do more development. There needs to be more money to hire people to come into small towns where there isn't infrastructure to get a 25, 28-year-old, medical personnel to come, right? They have to go an hour and a half to get something. Broadband, horrible, terrible. We need money to make that work. Get grocery stores back, like money for everything, right? Like, I hate to say it, that it comes down to money, and people to believe in it. You have to have structure. You can throw a bunch of money at something, but if you don't have people to do stuff with it, so the structure is needed as well. And I have other thoughts, but I don't want to upset anybody on maybe a new governor. I don't know. But anyway, there's a lot needed.
She went there. But I think you just said it, Tony. I think that, Caroline just said it. I mean, HRSA grants and really grants in general mostly do not allow us to use them for our infrastructure. How are you supposed to stand up these initiatives without investing in the infrastructure first? I mean, it's like we're putting the cart before the horse. We have all these great programs and things that we know will work, but if you don't have the people there and the infrastructure to carry them out, or you get your grant funding 10 months into the grant cycle, and so really you're not using it at all. Yeah, I mean, it's just like this never ending circle of, trying to get the grant and then trying to implement it before the grant's over. And then at the end, you're left with nothing and you've lost everything, all the work that you've been doing.
All right. Diana Collins, Melissa Clark, and Karen, y'all are, that's the order. Diana Collins first.
Hi. I tried to put my camera on, but it wasn't going on. Oh, here it comes. I just want to clarify, and I did come on a little late. Hi, Angie. Are we saying that there is no certification for peer recovery coaches in West Virginia? That's my first question.
Nope, that's not what we're saying. We were making a huge distinction between recovery coaches, community health workers. We know that there are about 4 different ones that exist in West Virginia. We know that there's also a working group to try and certify specifically community health workers. And we hope that that's going to kind of come sooner rather than later. So nope, we're not saying that there's no certification for nothing. That's not what we're saying.
Oh, okay. Well, there is a certified peer recovery in West Virginia. But
Correct.
Number 2, though, with HRSA, I always say that wrong. There is one designated HRSA facility in the Eastern Panhandle. You cannot even get into that particular place to even get an appointment. So not everyone is a designated facility. You have to apply for that. It's my understanding that they have to say it's okay for you to also be under HRSA. And so it's something that I've been trying to get, our entity, WVU Medicine, to be a part of, even to participate. Now, from the grant level, that's different. But to be a designated facility, there are so many benefits to that. And so that was my one question about peer recovery, but then also with the HRSA. Mm-hmm. It's so complicated.
Yeah, and so one of the things we did this morning is that and I don't know if you were here for it, but we specifically asked HRSA, and I think we're going to reach out to CMS for a similar thing, but they asked HRSA to bring its HAB director and the deputy director on and to talk about kind of what are they looking to do in this coming year, and what are they looking to do in the future, and they agreed to do it. So wherever Lavina is, we have a email that we need to send to Michael Carfin, who's the new director, and Tracy, I can't remember her last name right this second, at HRSA, about coming on to do this. And we could either do it honestly, and people should think about this, we could either do it as one of these meetings, or we could do it as a separate meeting where it's people who really are interested in learning more about HRSA or working more with HRSA for an Appalachian response, which is what I'm calling it. We can have a separate meeting and just kind of drill down on it. But as I told them, this wasn't just a conversation with community education group, that we need to figure this out for the entirety of the Appalachia region. And they were very open to it, I want to say. And so I think that sometimes it's that, like we had with PACHA, many of the President Advisory Council members who came to that PACHA meeting said, we didn't know what we didn't know. And I'm like, right. And what I want to do is make sure we bring resources, opportunity, and attention to the Appalachia region. And that's what I hope calls like this do, meetings with HRSA like that do. Not for our resource, but so that all of us can rise all boats. Melissa, you came on camera, you fixed your hair, and you did everything that said, I'm ready, girl. So go ahead.
I put my glasses on.
No, you did the whole thing. I saw it. I'm ready.
No. So one of the things that
Who are you? Because they don't know.
Oh, I'm sorry. Melissa Clark, Associate Director at AHEC West. We work in 3 counties in Western Maryland, the 3 Appalachian counties. We work in 2 counties in West Virginia, Mineral Hampshire. Sometimes will spill over into some of the others. And then a county or two in Pennsylvania, mostly Bedford County. But long story short, we do a lot of stuff. We are kind of like the dot connectors on a lot of this stuff. But the RCORE funding, which was the rural communities
opioid
response program. Yeah. So that was some money that was coming from HRSA that was so beneficial. I think one of the things HRSA needs to understand when you're speaking with them, especially, is that the designation, the federal designation of rural, they do tribal, they do rural, but there's no Appalachian. Why not? That's one of the things I've always said, because that way we spill into other regions. So, for example, Allegheny County has a rural designation, but we can't necessarily work with another county in another state that doesn't have it. So it just convolutes the whole process. So then we're like, literally, I can walk out of my office and be in West Virginia in a 5-minute walk. And I live 10 minutes from here, and I can be in Pennsylvania in 15 minutes from where I'm located. So it's so convoluted. So if we get money just for Allegheny County, we can only spend it in Allegheny County. They're not looking at like broadening. So that is my biggest beef with HRSA, is understanding they don't understand the region. And I'm not the only one. Everyone in this call, I'm sure, has some of this, whether it's county or state or whatever. But they need an Appalachian grant that we can use across the board, like they do with tribal, like they do with rural, like give us some specified dollars that we're able to do these things across the board, and it's not so limited.
Karen, how about you? You got something here? You're like, listen, leave me alone, Tony.
I agree with everybody. What everybody. We really lost her. I think she was that. It was like, leave me alone already. But so what I wanted to say to you, Melissa, is that one of the things that I led with in this call today with HRSA was about a designation. I said, my goal in life was that what there would be Native American, tribal, would be this, and then it would be a comma, and the Appalachia region. That's where we actually started out 2 years ago when we brought Lee on, was that we were like, okay, we need our own designation in every federal NOFO or in this. And then we learned that particularly with HHS, that literally every department would have to do it before every NOFO is released. It's not that the assistant secretary or the secretary can say, here's what we're doing. It doesn't work that way. We really thought that it did, or that we thought that we could get some sort of legislation to make it happen. And they're like, no. We've looked at this idea, and what you have to do is go right before every RFA, right before every department, and say, here's what the justification is for this and Appalachia designation. But I think that they can do it. But I think that, again, it's department by department, agency by agency, bureau by bureau, and that's how it right now, that's the process. So I think it's about, can you mandate a change in the process? I don't know. The other thing we really talk to them a lot about is a lot of what we're talking about here. I looked at it and I said, the real issue to me is the rural health calculator. If you say, you use Allegheny County, for example, if you say, well, my organization is across the street, but everybody from Allegheny County is coming to me for services, but that organization across the street, when they put their zip code in, it's like, you don't qualify. So it's got to be some other metric that you use. How many members from Allegheny County do you have on your client list? How many of this do you have on that? So we definitely talk to them about that being a challenge. I think that we really should think about, again, doing a meeting that is really just about this stuff.
Because I gotta tell you, I think I talk to people, we'll have federal meetings or state meetings. I think people think that's just Tony talking that crazy nonsense. That ain't nobody
Call
else.
me, I'll help because I'm all about it.
I mean, and I was like, and I'm like, the reality is that that's what I keep telling them. The idea of rurality, the idea of what a rural community looks like, number one, has changed. Number two is that you're asking us to create a response and build an infrastructure where for 20 years, nobody thought they had a problem, especially when it comes to HIV and hepatitis C. But now I got Kentucky and West Virginia going number one and number two with hepatitis C rates. I can't go to a bunch of HIV organizations and say, hey, why don't you add some Hep C work on top of what you're doing? Because those HIV organizations don't exist. Because for 20 years in this part of the country, 30 years in this part of the country, there wasn't an HIV. So now you want me to do that on top of talking to people who are exhausted from 2.5 decades of an opioid response, who are telling me, kick rocks, we're tired, we don't want to do nothing else, we're tired. And it's not that they're tired because they're mad or bad people. It's exhausting. Doing this work is exhausting and then doing it without resources is exhausting. And what I'm trying to tell them is that we got to do something to do a couple of things. One, we got to reinvigorate the folks in the behavioral health space. We've got to reinvigorate social folks that are doing the work in the space of harm reduction. We got to reinvigorate people who are doing community health clinic work, FQHC work, rural health clinic work, because the reality is that they're tired. And we never stopped and dealt with any of their trauma. Angie, I go back to that room that we sat in Morgan County a lot, because I feel like the big takeaway message that we missed in that room was the exhaustion of MAT providers, the exhaustion of emergency personnel, the exhaustion of behavioral health people, the exhaustion of public health professionals. And what do I mean when I say that? I mean, in our small towns, they're not picking up somebody they don't know.
Right.
They're not responding to somebody they don't know. We're responding to people that we went to high school with, your brothers and your sisters, your cousin. If you didn't know them, your brother knew them. And 2-3 decades of that, we tired. Not mad. I'm just tired. I don't know what else to do. I'm at my wit's end. And we don't talk about the work that we need to do with them to say, hey, are you okay? Hey.
Yeah. Tony, I think you're hitting it on the nail, because the last 2 years, that is something that I've been, really harping on, is we take on a lot of secondhand trauma, and nobody is validating that or giving out outlets for it. So yes, it is tiring, and trying to bust through these barriers one person at a time and help get them to where they're going. I had personally, I was born and raised here. So yeah, they are my friends, my family, my neighbors, the people who are sitting beside you in church. Really are. And a couple months ago, we had a patient in the ED, and one of our docs, who was the first doc like 7 years ago that got up to start bridge programs with Suboxone through the ED. And he come in and was talking with her, and I was sitting on the bed with her, and while he was talking, because I already knew that she had a lot of anxiety coming in. And I would put my hand on her leg and was, talking. And then I said to the doctor, I said, we went to high school together. So he knew that, I had this even more connection. When we left the room, he looked at me and said, that must be tough. Somebody you knew and you went to high school with. I said, so many. She's no different than almost every other person I see. So many, So yes, that is a real thing for us to be able to continue to do this work and build to do this work, is also self-care and addressing that secondhand trauma and the exhaustion from it.
Wow. Jill, do you guys offer a program or something like that for your providers that have been out there just in community doing this so long? I mean, do you just say, hey, you need to take a break? Or do you say, hey, here's a a golf tournament. I mean, I think that we've got to figure out ways to rub the provider on the back too. And I think this is not just providers. See, I think this is some of our policymakers too. See, because we see them saying, I don't care, let them die. Where did that come from? I don't think that these are bad people. I think these are tired people.
Sure. So we obviously, like, we offer trauma-informed care training. I think there are some other PCAs that do a better job at this. And in fact, I've been looking at the Ohio PCA because they have a really great, like, this manual and self-care for providers and folks in the clinic. So I think there's other PCAs that are doing it better. But we do offer trauma-informed care trainings. We talk a lot, especially like we have a monthly workforce roundtable. We have a behavioral health roundtable, an MOUD provider champion roundtable. So we try to offer lots of networking and community, because I think that's how we recover and that's how we heal, is in community. So we talk to people a lot in our clinics about team-based care and the importance of relying on each other and having a team that you can count on. Just because I think that's where a lot of that healing happens. When you have a tough day, if you can grieve together as a treatment team, you can come together as a treatment team, it builds you up and makes you a little bit more resilient to be able to face all the challenges that you have in a clinic. So we talk a lot about team-based care.
Perfect.
And I think that we should, we need to develop leaders that, you can do this from within yourself, right? Too. You don't have to wait for somebody else to do it for you. With me and my team, I mean, that's exactly what we do, because I recognize very early on, and I never want to put somebody, their recovery is first and foremost. And we put people in stressful situations and taking on a lot of secondhand trauma, then we can, lead that to a reoccurrence, right? So we had one specific day, all days, but this specific one, the whole team was working, trying to get a pregnant person linked. It was just unbelievable. And at the end of the day, my team was walking out the door saying goodbye with tears running down their face. And I said, hold up, shut the door, come back in, put your stuff down. Turn the lights off. We got in a circle, and I said, today, when we leave here, we leave knowing we done everything we could. The outcome today was good. We found a place and got the space secure for the night until she can get there tomorrow. And we're going to shake some of this off and know that we do the best we can with what we have at hand, and we go above and beyond before we take it home to our families. They could not walk out that door in tears and that flow over, right? So all kinds of things, then incentives. And let me tell you what, with providers, and I know we need a lot more than this, but chocolate goes a long daggone way. In that ED, when I'm recognizing somebody's having a bad day, I'll take them some chocolate. And you're just validating that they're having it and that you're there and you see it and you're appreciative. So we can do that within ourselves with our teams as well. Not saying we don't need higher level, support and interventions, but I preach that to everybody. We can start creating this for ourselves. We don't have to wait for somebody else to come in and do it for us.
Hey, Lee, I think that hopefully you're still here. I know Lee is actually on holiday, and I begged him to come on here today. If you're not here, I'm going to ask Lavina to do it. But I think that really this is one of those sessions we need to have at the summit that we're doing at the Greenbrier. I think we really need to talk about kind of chunks of this, right? We've asked HRSA to come do a presentation, but also about the how do we do the self-care piece, right? And how do we do the each other piece? How do we do the learning from each other? And that this does take a toll. Lee, can you talk about the summit at the Greenbrier? And I'm going to ask you to guarantee me a slot where we can get at least West Virginia, Kentucky, Ohio, Virginia to talk about kind of how do we make sure we're doing this self-care piece? I don't think it's just an ACEs piece. I don't think it's just secondary trauma piece. I think some of this is just real. Sometimes I just need to have a cry about this piece.
Yeah. I know a lot of y'all who are in Appalachia Partnership Consortium have had us, do pitches on Syndemic Summit before it's gone out over the email listserv. But just as a reminder, CEG is convening an Appalachian-wide Syndemic Summit at the Greenbrier in White Sulphur Springs, West Virginia, May 19, starting in the late afternoon, 20 and 21st. we're really thrilled to have 13 co-sponsoring organizations from across the region, from West Virginia School of Osteopathic Medicine, West Virginia Rural Health Association, and West Virginia Drug Intervention Institute. Really, this event came out of, I think, the work CEG has been doing with all of you for like the last 2.5, 3 years, right? Really thinking about how we define interventions in a new way for this region and make change. And I think there's absolutely room, as we think about this agenda, to include sort of the conversation of self-care and the movement and that work as well. So Levine and I are taking furious notes through the conversation.
Perfect. And I know we started a few minutes late and we were at the hour, but the last thing I'm going to ask is that I know that we've agreed to send a follow-up note to, no, Lee, don't you disappear, because this is critically for you. Is that we've agreed to send a note to HRSA, to Michael Carfin, and to Tracy, following up on our meeting this morning. If everyone's okay with it, I'd like to send them a copy of this conversation, because I want them to understand that it's not just me talking to them about this stuff, but it's a region wide. And I think this idea of what they need to be doing, let's get this in front of them, and then let's prioritize getting them. Yeah, I mean, and maybe it's not that we need to do it on this call. Maybe we can put out a who's interested in just having a conversation with HRSA and getting them there, no meeting where all we do is drill down with them. Yeah, cool. Andrew, you got your hand up.
Yeah, thanks, Tony. Since we are coming up on the end of the hour, I just wanted to throw in one more thing, because I'm hoping that this will spark people replicating it across the state and Appalachia for that matter. But low barrier naloxone, for a reversal of overdoses, we were able to get, I mean, literally their Narcan pickup boxes. They look just like the old school newspaper little box sitting outside the ED. On average in this hospital, by us putting in the orders, we would give out about 11 take-home Narcan kits a month. We did almost 200 in 3 weeks at sitting in the foyer of the ED. It's just take what you need. And I mean, it's just low barrier. We also have it at our crisis detox facility at our outpatient Suboxone, and getting ready to put them in other WVU buildings. It is just amazing now that Narcan has went over the counter, which, we've been trying to do since 1996. And it is really low barrier and people have access to it. And it's just a beautiful thing. It's like having Save a Life Day every day in your county. It's there.
Ain't it fun, Angie? Ain't it funny what money will do?
Yes, ma'am. Yeah, it all comes down to that almighty dollar. But if you're looking for what we actually wrote it up, me and my partner in crime, it is in the West Virginia Hope and Action Alliance newsletter. If you just scroll down from our executive director, when she puts in the attachments, the whole write-up is actually in there of how we did it and our results.
Can you make sure we get it, and we'll send it out with the links that we send out after this meeting? Is that, Lavina, am I saying something that we can do or something that we cannot do?
No, that's perfect, actually. I was going to ask that.
Okay, perfect. Thank you. All right, because I have no idea what we really can do and what we can't do. I just say stuff, and because they all make it happen. But Melissa, you had your hand up. Karen, you have a last word. Jill, you have a last word, and then we're out of here. Melissa, you first.
I was clapping.
Okay.
West Virginia, yeah, no, I'm happy. West Virginia's finally slowly coming along.
All right, Karen.
Yes, I got cut off. My apologies. So yes, this has been extremely informative for me. I have enjoyed this session because it is interactive. I do have lots of thoughts on community health workers, and absolutely wish that I could have one at the clinic, because they have been in the community working. I know of one, and she has done leaps and bounds with health disparity, connecting with folks. And Yes, yes. So looking at that. But the last thing I do want to say is remember tomorrow is Cover West Virginia. So there are places that will help folks sign up for insurance. So I posted something on our webpage as well, our Facebook page. So
all right, if you have a link down below for where people can go, if you put it in the chat, we'll make sure it gets out. Or Lavina will have to call you and track you down and get some info, because I will.
Okay. Okay.
All right, Jill, how about you?
I guess just final thoughts or final words. I read or heard somewhere, what if we started every meeting with, in 100 years, this conversation is not going to matter. So now let's have this meeting. But I think we all work in healthcare, and that's not the case for us. The conversations that we have had today, they're going to affect cultures, work cultures and systems, and they're going to affect patients' lives. And then that's going to have a ripple effect on the people that they love and the people that they take care of. It's going to have effect on communities and families and generations after generations. So I think the work that you guys are doing, it's important, and these conversations are important. So thank you for letting me be a part of it.
Perfect. I want to thank you all. I think, so often we work so hard and we work so many hours and we're doing what we do that we don't look up. And then I think when I look up and I see you all saying the same thing, I think it makes me say, okay, right. We gotta keep doing what we're doing too. And we got to get these people in here to hear that it's not just Tony thinking crazy stuff. It's really out there, and that I want us always sticking together, because I always say they can't divide us if we're in it together. You can't come over here and talk to Angie and then come over here and talk to Jill and say, no, we're in this together. So I want to thank you all. Like I always say, the Appalachia region is 13 states, 26 million people, 423 counties according to ARC, and our job is to bring resources, opportunity, and attention so that those folks don't have to suffer. And in order to do that, we must be consistent in what we do. So I want to thank all of you for your consistency. I want to thank you for your commitment. And I most importantly want to thank you for your passion, because without that, I don't think we get through this, because it sure ain't about the money. All right. Thank you, everybody. Have an amazing first of the year. Have an amazing year. Have an amazing month. And we're going to send out a separate email, I think, because I think I want to do this HRSA meeting separate, is what I think I want to do. And so I'm hoping that those of you that were here today will join us, and we look forward to seeing you again next month. All right? Have a great one, everybody. Thanks. Bye. Angie, it's good seeing you.
Good seeing you, Tony. Thank you for all the great work that you do.
Thank you.
Yep.